A very good evening, ladies and gentlemen. Thank you so much for joining us once again. This is our, I suppose, the start of this year's installment 2022 of Cancer and I, which is an awareness section for members of the general public. And joining us this evening, we have a very special guest, Dr. Paul Silvandas, consultant colorectal and laparoscopic surgeon with Gleneagles, Kuala Lumpur. Good evening, doctor. Thank you so much for joining us.
Hey, good evening, Murli. Yeah, it's great to be here, especially to share on a subject that I'm very passionate about.
Right. Lovely, and such a pleasure and an honor for us to have you with us as well this evening. So, ladies and gentlemen, as you're settling down, I hope no one was caught in the KL jam. And if you were, hope you all have kind of settled into post-dinner, or if you're starting on dinner, put this on. It's running on your Facebook. And feel free to kind of chip in, put in your questions, any queries that you may have to Dr. Paul. He'll be very happy to kind of answer them, field them right at the end of the session. And this evening, we're talking about shining a light on colorectal cancer. And this is very, very kind of apt because this month is Colorectal Cancer Awareness Month. And colorectal cancer, as much as we know, unfortunately, is one of the most kind of severe cancers. A lot of people in Malaysia suffer from colorectal cancer, and what's good is, or bad, I suppose, it's that it affects both men and women. So it's not a get out of jail free card for the gentleman in this case. Yeah. So together to speak to us this evening is Dr. Paul, and Dr. Paul is going to speak to us about everything, I suppose, A to Z about the cancer, which is colorectal cancer. But first, before we begin, Doc, just to kind of ask you, and this is always something we kind of ask our guests, why colorectal? Was there no other better part?
Yeah. So to start off with, you should ask me why. I mean, I actually didn't want to do. My parents never wanted me to do medicine as a choice initially. Okay. My mom was a staff nurse. My dad really wasn't that keen. My mom working at night, and he always thought banking line or engineering would be better. So, but I told my dad one day that, after my Form 6, I was thinking of medicine. No, I said, either send me to medical school or I'll pick up the guitar and go to a bar. And no Indian parent is going to enjoy that. So, but in colorectal itself is once I finish general surgery, my mentor in Sramban that time was a colorectal surgeon. So it just became very natural that I could do that. And I must say, while they say the brain is the boss, but we think they are the boss, because if you can't open your bowels, it can be a really shitty day.
Yep. And speaking about shitty days, how bad does it get in terms of, when you go home, is it like sometimes you're just inundated with the smell, the taste, or is it like?
No, it's nothing like that, because we actually tend to, even though it's the anus, but we tend to actually operate in a very clean environment after cleaning up and stuff like that. So yeah, no issues at all. My wife has no issue with it at all.
Oh wow. Okay. Yeah. Got it, Doc. So it's as clean as clean can get. Lovely. Yeah. Lovely. Right. What is this? Okay. So Doc, without further ado, please allow me to, turn the screen over to you. Dr. Paul is going to speak to us. He's going to share some slides, give us a few insights into colorectal cancer, and then we can take some questions all together. Thanks, Doc. Over to you.
All right. Thanks, Dr. Murali, and hi, everyone. I am going to share my screen now, and just give me a minute. And I'm going to go to the presenter mode. And yes, my screen is on. So today I'll be talking about colorectal cancer, and it's a cancer that I'm very passionate about. And really this is because I remember one of the professors that I knew, Professor Monson, who used to be in UK and now is in US. He always said, in colorectal cancer, it's one of the cancers that can be prevented because it takes a long time from a polyp to a cancer compared to anything else like breast cancer or any other cancer. By the time there's a small cancer, it's already a cancer. But because of the polyp to cancer sequence, which takes a long period of time, it's one of the cancers that can be prevented. So these are just to show you, the data about the percentage of cancers around the world. Just looking at the incidence around the world, now colorectal is number 3 as far as incidence around the world. And as far as death is number 2 around the world. And incidence rate, looking at Malaysia, looking at the Malaysian data, one is from 2007 to 2012, and again, the later part, you can see as the age increases, the incidence increases in males, and the same thing for female. I mean, this is just going to keep increasing. As our population tend to grow older, this is going to keep increasing. And when it comes to the race, the different racial groups in Malaysia, what was seen in this observation was really the Chinese ethnic group tend to have a higher incidence rate. But one very interesting compared to from 2007 to 2011, and then in the later part to 2016, you can see there's a slight decrease in the Chinese population. And I think one key point that I personally think is because the Chinese population in Malaysia tend to go for more health screening compared to the other races. Now, when it came to by stages, sadly, you can see even in the later years, most colon, rectal cancers were in the later stages compared to the earlier stages. And this is sad. We should actually prevent cancer, and if you are picking up cancer, we should pick them up in the earlier stage so that we can give a better cure rate. Now, the area of the this is the whole colon that's about 1 meter long, and majority of the cancers tend to happen in the last 25 to 40 centimeters, and that's where 50% of all cancers are going to happen. So it's really easy to look into this area with a camera. What are the signs that I should look for if that could point that I may be having a cancer? Now, it can be from constipation to diarrhea, blood in the stool, especially when you're older, about 40 years old. Really is an ominous sign that something is not right. So it's always good to go and talk to your doctor, or suddenly you feel your stools are narrower. Suddenly you do a blood test, during routine blood test, and see, hey, my normal hemoglobin, the previous year was 40, and now it's dropped down to 9 or something. You're getting pain in your tummy all the time, or you're losing weight suddenly without diet or exercising, or feeling very tired. Yeah, you need to go get these symptoms checked with your local doctor. And of course, if you're going to the toilet more often, I mean, if you're going once a day, now suddenly going 3-4 times, or sometimes you're constipated, sometimes you're having a little bit of diarrhea, or after you evacuate, you feel like something is there, or feel you need to rush to the toilet. Now, all these are symptoms that you need to go talk to your doctor. And cancer doesn't just affect just certain groups of people. I mean, even some very famous people, Queen Mother, she had cancer, survived that. Those who remember the lovely Farrah Fawcett from Charlie's Angel, she died with colon cancer. The late President Reagan also had a stage 2 colon cancer and survived that actually. And of course, those of you who remember the English football captain who won the World Cup, Bobby Moore, he had colon cancer. And of course, recently, those of you who follow the Chadwick who died of colon cancer at a very young age, just at 40 something. And so it affects all of us. All of us are going to be at risk of it. And so we should be able to prevent that. Now, what is the best way of screening? Now, you're going to see lots of different things in this slide, and this is from the American Gastroenterology Association. But still, some of the best way to screen for colon cancer and to prevent colon cancer is actually to get a colonoscope done. It's virtually a small tube that runs down the whole large intestine to look for cancer or small polyps that can be removed. And many other tests that are being talked about, they're not as great to prevent colon cancer. Now, many people ask me, Doc, I go to the screening center, I do this test, tumor markers. Does tumor marker help me prevent cancer? Well, it's not diagnostic, right? It's prognostic. We don't do it to diagnose cancer. And so I like to tell you a story here. This was many years ago when I worked in a different hospital. A gentleman who bought this screening package from one of these places, and he went for a regular screening package. So he did his every year, he did his checker, he did his ultrasound level, and he did his chest x-ray. And every year the tumor marker was normal and he was given a clean bill of health. And this he bought when he was 40 years old. And when he was 52, 53, suddenly one day he realized tumor marker, the CA was normal, had jumped up 200 times to over 200. Now, at that point, he panicked. He came to see the oncologist and myself. We did a CT scan and a scope, and we found that he had tumor in his lungs, in his liver, and locally. Sadly, in spite of whatever little treatment we were able to offer him, he finally passed on. And I remember at that point, he asked me one question: why didn't anybody tell me that at 50, I should have gone for a screening scope? I could not answer him. And I think the lack of knowledge in him, because nobody shared that knowledge. And that's why we want to share that you need to get screened. And what age should we get screened? This is an old picture that I used to have for many years ago, when we tell that when we are 50, you should go see your doctor and talk to him about getting a screening colonoscope. But that has recently changed, again, from the American Society, which talked about, hey, 45 is the new 50, right? So now we're saying that you should get screened earlier because you're able to pick up, there's another group of patients that we don't want to miss developing this cancer. And what do we do when we do colonoscope? I'm just going to show a quick short video. Just a patient of mine came in for a screening colonoscope. And then what we find is these small polyps. And if we find it, we remove it. And these polyps are the ones, we call them adenomatous polyps. And over a 10-year period, because they have some dysplastic gel, can become a cancer. And so a quick lasso around the polyp and snip, and it's out. And it's quickly done, right? And so that's very important. And so if by chance someone's polyp has already become a cancer, we know the 5-year survival is better if it's found at a local stage, where it's a carcinoma in situ or a local stage. Then more than 90% have a survival rate of more than 5 years. Now, if it's diagnosed at a late stage, that it's going to go down dramatically. Now, what about treatment in colon and rectal cancer? There are lots of new things that are happening as far as surgery and targeted therapy and chemotherapy. All these is a combination. Now, when somebody has a cancer, it's a combination of work between the surgeon, the oncologist, and the pathologist. And then we all are thinking of the best way to treat this patient. And when it comes to surgery, some of the new things that we do is like, a large polyp that we can remove through the scope itself. Today, I was doing a case where a flat polyp where my gastroenterology colleague was trying to remove but could not remove. So we need to do a surgically laparoscopy, these small holes on the abdomen, and do the surgery. A new thing that has also happened in recent years for the lower part, the rectum cancer itself, is what's called a robotic surgery. And I'm just quickly running a video here where we're doing robotic dissection of the last part of the colon, which we call the rectum. I'll just show you what's available out there for you. So there's lots of advancement that we have seen as far as treatment itself. But don't forget, the best thing is still to get screened. Now, how do we prevent this colon cancer? How can we prevent? I think the number one thing is to eat healthy. Make sure you're eating lots of veggies and greens in your diet. Now, people ask me this question, Doc, do you follow what you share? And it's true. You can ask my wife. Half my plate is always veggie. I don't eat as much carbo just to keep healthy and fit. but really eating lots of veggie and fiber is important. And the second thing is avoid processed meat and red meat. I mean, avoid processed meat by all chance you can, but red meat itself, decrease the amount, not frequently. Eat more fish, eat more chicken, but yeah, that would be great. Then quit smoking, quit alcohol, because we know that this increases the risk of someone getting colon and rectal cancer. And lastly, exercise and lose weight. So these are all great stuff to do for us to keep the risk of getting colon cancer. So I'm coming to my last few slides here. And so what will be the take-home message? One, we need to know that colorectal cancer is increasing throughout the world, and in Malaysia, we see the same pattern. Two, the best prevention is still screening. There is no doubt that screening will help to prevent colon cancer. I myself have gone for my own scopes as recently as last year. Thirdly, I remember the new screening age is no more 50, it's 45. So if you're 45 and you have no symptom, you need to get screened. If you're 40 and you're starting to have some of these symptoms, please talk to your doctor so that you can get screened. And last but not least, yes, if you have symptoms, go get screened early. Now, this is a card that you should be giving everybody who's 50 years old. Looks grows up and is ready for a colonoscope. So when 45, put this card in and send it to them, because it reminds them the importance of getting screened. And I think even for other diseases, you're above 40, 45, you need a stress test and things like that. Look at your heart. The same thing is get your colon checked. Now, I think that is my last slides. And, I'm going to try to answer as many questions today as possible. But if anybody else want to email me on the email address which is up there, or WhatsApp, my clinic mobile number, I'll be happy to answer those questions if we can't answer them live today. Murli, I'm going to give that back to you, and I'm going to stop share here.
Oh, lovely. And thanks so much. And really, I think that's a really good kind of strong message from Dr. Paul today on the importance of screening. And Doc, there's already, I think, a nice couple of questions coming out from us from different social media as well as through our WhatsApp channels. If you're okay to take some questions, Doc.
Yes.
Oh, lovely. Always good, Doc. And so the first question is, Doc, on average, how frequently should I get a scope? I think you mentioned, so this viewer of ours asks, when I do start screening at 45, should I then repeat, how frequently should I repeat my scopes?
Yeah, so I'll tell you what the guidelines say. The guideline tells us that you do it every 10 years. You get a scope at 45, it is clear, then you just do it after 10 years, right? Okay. So you don't need to do it in between. Now, if they find a polyp and they've removed a polyp, then they're going to do it earlier in the next 2 to 3 years. That's because sometimes when you have one polyp, you may have another small polyp behind the fold of the large intestine. And not to miss that, most of us would recommend a scope within the next 2 to 3 years.
Okay. Got it, Doc. Now, and when we're on that, somebody asks, rather than doing a colonoscope, can I do a CT as a screening mechanism?
So if you look at the slide I showed earlier, one of the things is what's called a CT colonoscope. Now, most of us don't recommend it as first choice, but I know there have been patients who have asked me as well, Doc, I don't want to go under a colonoscope. I don't want to be sedated. I'm afraid. I've heard about things. So can I go for a CT? So the guideline does tell us that going for a CT colonoscope once in every 5 years. Now, that's less than compared to doing a normal colonoscope. But the problem of a CT colonoscope is this. Now, if you do a screening colonoscope and you find a polyp, then you still need to come and see one of the doctors to do a normal colonoscope to remove that. And I think the biggest fear of colonoscope has been, including myself, even though I am a colorectal surgeon, it's like, whoa, I need to be sedated. I'm going to lose control of myself. But it's just for quick 5-10 minutes and we are done. And it's you know, most colonoscopes are done in very good sedation. Most of us use an anesthetic to give, so you're very safe, in a very safe environment doing a colonoscope.
Okay. And this is, I think, a very, very interesting question. Doctor, thank you so much for your sharing. You're one of the few doctors who have told us they've gone for a colonoscope. Well, I think people are not coming clean with what tests you're doing. So this viewer of ours asks, could you share with us the experience from start to finish of getting a colonoscopy done? Oh, lovely.
Sure. So basically, when I had a colonoscope, I had to go see my doctor. He said, you're this age now, you need a colonoscope. So they give you these packets to drink the day before, because your bowel has to be clean. Otherwise, they can miss small polyps. So the 2 days before, I don't eat too much of fiber. And then I drink 4 liters of fluid the day before. So it's at 7, 6, 7, and 9, and early morning 5 o'clock. So I drink this, and by the next day, my poo is just clear water or light yellow. I get into the hospital. My wife drives me to the hospital 7:30. The anesthetist sees me in the scope room together. And so sedation, they use this quite strong medicine, things like Domicum, a sleeping medicine, Pethidine, fentanyl, and propofol. Those of you remember propofol is what Michael Jackson used, but that in an uncontrolled environment. But here, the anesthetist is giving you, you're very comfortable. Then my endoscopist did a scope for me, just 10 minutes. He was in and out, see what he wanted to see, biopsy what he wanted out. And in fact, I was waking up my eyes and asking him, what is this? What is this? My wife was telling me this, but I was very comfortable. And the next 20 minutes, I was awake. I woke up, I drank, I had something to food. Of course, they observe you for another 2 hours or so, make sure your blood pressure, oxygen are good before you can go home. Yeah, so it's a very comfortable, very safe procedure. Most big hospitals can do 400, 500 scopes a month. Really, that is the amount of up scope and down scope that most big hospitals will be able to do.
Lovely, Doc. And so another viewer, I think, asks, is it recommended to also get a gastroscope at the same time as when you get a colonoscope?
All right. So a lot of us do offer a screening gastroscope. It means from the top when you're above 45. And that's because, actually the screening gastroscope guideline comes from the Japan, Korea, China region, where incidence of gastric cancer is much higher. And in Malaysia itself, the issue is with this bacteria called H. pylori, right, which causes gastritis. It's quite endemic here. So a lot of us would recommend that, get the upper scope done as well. And we've picked up lots of these people with this bacteria, which can be cured with some antibiotics and some acid-reducing agent for 2 weeks, because that bacteria also is precancerous. Over a long period of time, people can develop gastric cancer from that. So yeah, most of us would recommend that.
Lovely. So I think it's a since you are there, just like get it done at the same.
Another 3 to 5 minutes. Yeah.
Yep. Doc, there's a subsequent question to what you were describing to us earlier, and I think this is this person asks. So will I get sedation? Is it an automatic thing, or do you need to speak to the doctor about it? I think in terms of colonoscopy.
Yes, most of the time, the doctor will give you a sedation. We want you to be comfortable. Okay, when I had my scope, upper scope many years ago, I wanted them to do for me without sedation. Now, I just want to feel how it was. And in government practice, we used to do that. But one of the things, I was okay with it. But generally, I want my patient said, Doc, put me to sleep. They want to be really comfortable. And I want them to be comfortable because I don't want them to be traumatized, so that they will come back in 10 years' time for the next screen. Because, the American recommendation, you need to get screened every 10 years. So it's important. If they don't like it once, they will never come back. And we have missed that opportunity to help prevent colon cancer.
Right. Doc, while we're on that as well, and I think it's worth kind of getting you to reinforce this point about how early detection, unlike a lot of other cancers, like our lung cancer, for example, miserable cancer to have and so difficult to detect. We have this golden opportunity with colorectal cancer.
Yes.
I think you were saying, that this is one of the cancers where you pick up in the polyp stage. So this is literally stage 0, yeah?
Yeah. It's precancerous, it's completely precancerous, and you have this time to play with. And so I think it's so important to get this done. I had a friend in church. This is when at that point the guideline was 50 in the US. He was American in my church, and he said 50. He just decided to get a colonoscope, and it's already a cancer. But the good thing was, it was stage 1 cancer. They did surgery. I didn't need chemotherapy. He's lived 20 years, and he's doing well. So it is so important, to get that screening test done. And like everything in life, we are growing old. It is a decaying body, so we all be at risk for all kinds of diseases. And part of that screening, other than screening your blood and getting a stress test and things like that, don't forget your colon. And I think the problem with colonoscopy, most people feel, is kind of invasive. I can't get an ultrasound and look for colon cancer or colon polyps. So people feel a bit more reluctant to come. But I assure you, it is the best way to get screened, and it helps to prevent. Remove the polyp, it'll be great.
Right. Absolutely, Doc. Doc, also kind of just to kind of get you on this point to speak to our viewers as well, because picking it up early means that you get a lot less treatment as well.
Yeah. So if it's like I had a patient a few days ago, very close at the bottom, a small cancer, and we just go through the rectum under GA, resect that part. And probably that's the only treatment he or she will need, and no big scars, nothing like that. So best is to prevent. If not, pick it up early, because once it reaches the liver, the lung, stage 4, your cancer markers are high. We can only control it to a certain level, and then one day it's going to escape us. Yeah.
We have another question, Doc, from a colleague who asks, can you summarize the symptoms of when there's something wrong with your colon? Dr. Paul shared this with us earlier, and maybe Dr. Paul can show us that slide again.
You want me to show that slide?
If it is helpful, Doc.
Yeah, of course. Let me share that again. How do I share? I think I'll come down to I think this really talks about the whole thing. I think one of the most common things that people get worried is if they see blood in your stool, right? So growing older, if you see blood, now you need to remember that blood in the stool, the commonest thing is still the common thing, which is hemorrhoid, piles, chichong, as they call it in China, wase in Malay. So that is still the commonest thing. So don't get worried if you see blood in the stool, or something is really wrong. But blood in the stool always means you definitely need to go see a doctor already. Don't wait. Don't say, oh, it's a little bit of blood, I'll wait for another 6 months. That is not good, because then if by chance you have cancer, you're delaying your diagnosis. You see blood in your stool, go see your doctor. Then the other things is change in bowel. So you're always opening your bowel well, and suddenly you get constipated. Or opening your bowel well, now you're having diarrhea, going to the toilet 3-4 times, watery stool, mucousy stool, something is not right. Narrow stools, very thin. Suddenly you say, hey, why is my stool that is look like, different, right? So, and then if you do your blood test, your hemoglobin drops. You get this gaseous feeling, very non-specific. Could be anything from gallstones, but cancer is something else we always keep in mind. You're losing weight suddenly. You're not on diet. You're not over-exercising, and suddenly your weight keeps dropping. Again, you need to see your doctor. He'll do a battery of tests, of course, but this is could be the sign as well. And then you're always feeling tired after work. We always hear stories of this, and we've had patients who suddenly just feel very tired. During the pandemic, I've had patients who just suddenly feeling tired, did ultrasound. There's a big mass, already a cancer, 60-year-old patient. So it is important that any of these changes, you should go see your doctor and have a chat. But don't forget, don't wait for this. That is the important message. Just as you grow older, get it checked so you don't have to wait for symptom and worry about it.
Right, absolutely, Doc. And I think one of the really strong points that you're making, which is of benefit to the viewer, ladies and gentlemen, because even in my own practice, I see a lot of people who just tend to self-diagnose when they see blood in their stool. Within their mind, they've already done the colonoscope and decided that it's hemorrhoids.
Yeah, Murli, I must tell you, I just share a real life story. One of my doctors, someone I knew, she had some bleeding and she was 40 something and she thought she just piles. And then after a few months, only she decided to go get a colonoscopy. She had a low rectal tumor, that means last part tumor. And we had to give her radiotherapy, chemotherapy, did surgery. She had to carry a bag for a while, close the bag, and all kinds of things. But even she thought she just had piles, and she's a medical person.
Right.
So
exactly.
So it's so important. Don't ignore your symptoms, right? When there's blood, anything else, talk to your doctor. Let them decide.
Doc, while we're on this kind of looking at symptoms how do you think about people with a family history? And I remember that they're much more prone as well. Anything that should advise in terms of early screening?
Yeah, so it's based on what age the family had, So if say a parent had at 50 years old, then of course you should start screening at 40 years. So 10 years before the diagnosis. More than 2 people in the family have, or uncle and dad have it, then your risk goes up, right? There must be a hereditary or a genetic issue going on. So you need to start screening much earlier. Otherwise, you may miss the boat, right? If you screen later, then you're going to miss the boat. Murli, I love sharing stories about my patient because I think that's
absolutely
really
that really catches.
So I had this Chinese gentleman. His dad had cancer early at 50, so he decided at 40 years old to go get screened, and it was fantastic. He got screened. He had nothing. His next screening was at 50, and he didn't come.
Oh, dear.
He waited till 54. And he started bleeding. He came, we scoped, he had a cancer, we did surgery, he had chemo, radio. Many years later, he developed mets to his liver, lung, brain, and he passed on. And I remember him again telling me, I should have come in the 10th year or 9th year. I just missed it, and I delayed it until I had symptoms. And so he thought the one scope he did, wow, great. He was screened, but he missed that boat,
Yeah.
So if you have family history, you need to get screened based on that. So 45 or earlier. So if you have a family history, then you definitely need to go to start earlier. So I've got some very young patient. I've got a young Malay gentleman who's just 27 years old and diagnosed, so that's strong family history. I've got another Indian gentleman, 33, when I first came to clinicals, and but now he's cancer free. He's already year 11 surviving in that. So get screened at 45. You got family history, then of course you want to do it slightly earlier.
Right. Doc, there's a question from another viewer who asked, and I think this is pertaining to what you were mentioning a little earlier about as well. Do all colorectal surgeries end up with patients needing a stoma bag, I think?
No, definitely not. In fact, say compared to when I was in medical school, if your cancer was in the last 8 centimeters, you are guaranteed to carry a bag for the rest of your life.
Okay.
But now we've moved on. We can do what's called Splinter saving surgeries. So even the very low ones, the oncologists help us to shrink it down by giving chemo and radio. You may have a temporary bag. The number of cases that need permanent bags are much lower. They have to be very aggressive cancer, that means poorly differentiated type, or they're already involving the sphincter, going through the sphincter. Then we have no choice, because to save you from that cancer, we have to sacrifice the sphincter and carry a permanent bag. So the number of people having, if people look up what's APR, or completely removing the rectum and the anus, for colorectal cancer has come down tremendously in the last 10 years. And as technology keeps improving, we are improving that technique as well.
Absolutely lovely. Because for a lot of us, I think one of the things that we hear from patients is that they're terrified of keeping a bag. So that's really a very relieving news to hear.
Yes.
And you were telling us, Doc, as well, that nowadays it's not, I mean, I remember that we always talk about surgery as the first line, but now there's other options first, yeah? You were saying about
It's
using
a
chemotherapy
combination.
first, yeah.
Yeah, it's a combination. So for rectum, the lower part, especially the lower 8 centimeters, so most of the time, because they also come in a later stage, so T3, that means it's slightly more. So the oncologist will give chemotherapy and radiotherapy to shrink the tumor, but they still, most of them will end up with surgery.
Mm-hmm.
But it's just,
so it's just that you do chemo first and then surgery subsequently.
That's right. So instead of the other way around, so you kind of shrink it down so you can do better surgery.
Right, absolutely. And what are your kind of thoughts about people who are now, I mean, most of your cases, are they early cases, are they late cases? Because we hear that, you know, colorectal cancer is still diagnosed very late.
Yeah, I think in most of our patients that come to see us are between stage 2 to 3. So they're not, that there are people in stage 4, but we do see a lot of stage 2 and 3. But this last 1 year as well is the same, because some people are coming a bit later because the pandemic, they're not getting screened. Yep. They have symptoms, they take delay. So we're seeing slightly more stage 3, you know, the 1, 2, 3, 4. So we're seeing slightly more stage 3. But I think we hope that more people are aware now the pandemic is coming downwards. More people are coming back for their regular checkup, screening. So we hope we'll start picking up things earlier or help to prevent.
Absolutely, Doc. And so, what is this? We've got a question from another viewer on the consumption of fiber. So this viewer asks us, is there any particular brand you would recommend? There you go. So Doc, I mean, about fiber, the use of fiber, people now start, you know, putting up different brands of fiber, roughage to kind of take into their diet. Any thoughts on that? Doc, what's
I
helpful?
thought the natural fiber is the best fiber. Everything else you add is you're making somebody else, some company rich, right? So the recommendation is 25 grams for males, which is body weight, and then 18 for females. Now, and the Australian study had showed if you take 6 to 9 portions of vegetable and fruits per day, you will decrease your incidence of colon cancer. So what do I mean by 6? That means the easiest way to, so if it's 1 glass of uncooked salad or a fruit, that is called 1 portion. If it's cooked, half a glass is called 1 portion. The easiest way to remember this, you wake up in the morning, instead of eating a roti canai, have some oats and an apple or pear or something like that. That's already 1 to 2 portions. At lunch, make sure half your plate is veggies. Right. Instead of the other way around, half your plate is veggie, quarter is protein, and quarter is rice or noodles. Right. Now, that half plate will already be 2 to 3 portions. Do the dinner the same thing. Instead of having ice cream, have a fruit, a banana, a papaya, so that you can easily hit 6 to 9 portions a day. Now, one of the questions many people have asked me, Doc, do you follow what you talk about? You can ask my wife, I follow exactly what I thought, because, you know, I did it actually not because of fiber. I did it because I want to lose weight. I used to be quite big before. I used to be like 80 kgs. So to lose weight and to be fit, I had to use this diet, but of course, it's helpful for my colon as well. I'm sure it's for everybody else.
Right. Absolutely, Doc. So we're coming. I think there's just a couple of more questions. Doc, I am a lady with I think my aunt and I don't know. I think this is her another relative has colorectal cancer, and I've been trying to stay healthy, but I am worried about going for a colonoscope. I think she asks whether you'd be able to offer some advice to kind of encourage her to go for a screen. Any thoughts on this?
Ma'am, you know, some of the oldest people we have scoped is even 90 years old because they have symptoms. My dad, who's 86, had a scope in 2016 last. And so, and that time he's already going to be 80 already. So, ma'am, the risks are very low. Nobody can say 100%, but the risks are very low. It is so much safe today, safe compared to even 20 years ago. The anesthetist is there to give you good sedation. The endoscopist is there to make sure the scope is done safely. Don't get worried. Go talk to your doctor. Go talk to your doctor, and then he'll be able to advise you and take it from there. And really, if you still don't want to go for a colonoscope, then at least please go for a CT colonoscope every 5 years, and that'll pick up. Then
and then you can
take it from there.
Right, right. Doc, there's a question on how much does colonoscopies cost?
All right, so the scope can cost different in different hospitals. In government, it's free. Right. In government, it's going to be free. The universities as well will be free. So you come to private. I mean, you can go to a smaller hospital. It may be less. It can range anything from 1,500 to 3,000 in different hospitals. So there's a range of it in different hospitals.
Right. But I think one of the ways to encourage our viewers to think about this is, as you're saying, I think it's a life-altering kind of expense or an investment. And I think if you calculated it, 3,000 ringgit, I mean, if it was 3,000 ringgit divided by about 10 years, that's maybe less than going out for one Chinese meal.
You're exactly right. People don't realize that some people go for haircuts for 200 ringgit. And then if you think for the whole year, that'll be more than what you go for a health. And I always tell people, health is your best investment, right? Health is if you don't invest in your health, sooner or later things will creep up and you'll miss it.
Yeah. Oh, I was just reminded, Doc, and this is perhaps interesting to share to our viewers as well. Hey, look, we change iPhones, I think, every couple of years now. It doesn't go past the 3 years. This one, you do a test, it's 3,000, but lasts you for 10 years. I think that's a good way to look at it.
I know.
Will do. Doc, and there's another question on besides what is this colonoscopies and regular kind of improvement, diet intake, is there any kind of benefit from physical activity?
Yes.
And relating to colorectal cancer? Yeah,
so the data is clear. If you have a lower weight, your risk of colon and rectal cancer will be lower. So exercise definitely helps. Exercise definitely helps. So I think keeping physically active. Now, it's not only going to help in colon rectal cancer, it's going to help in lots of different diseases, from heart disease to every other cancer as well. So keeping yourself active, 30 minutes 5 times a week actively, whether a walk or a run or some sort of activity, will definitely decrease your risk of developing any kind of cancers for that. Right?
Will do. Look, there's a question from another viewer. Have done a colonoscopy 2 years ago. Doctor says it's clear and just hemorrhoids, but piles still bleeding off and on. Do you think that another colonoscopy is warranted, or are there some other ideas of management that should be?
So if you are confident that your endoscopist has done a good colonoscope, and you think it's just a bleeding hemorrhoids, you can go back to your doctor. You can or take your CD to another doctor and let them have a look. And if it's just a bleeding hemorrhoids, they can treat the hemorrhoids and it should settle. If they've never done a colonoscope and they're bleeding, of course, then a colonoscope is warranted.
It's warranted. Absolutely, Doc. Doc, there's an interesting question on bowel prep. Why is it that I get very dizzy? And why during consumption of the fluid, and then continues on to ask, is this kind of medication necessary? And I think you mentioned that slightly ago.
So you need to take there are many different medications to clean the bowel. Some requires up to 4 liters of fluid, some a bit less. The idea is you need to clean, the colon and rectum keeps all the fecal matter. So it's going to be dirty. If it's not clean, we're not going to be able to see well. And if you can't see well, you're going to miss polyps. You can even miss a small cancer. Tell you a story. One of my colleagues was scoping a lady, and the bowel prep was not good. They actually missed a small cancer. And while on follow-up with a gastro who did the blood test and saw that her blood tumor marker was slightly climbing, went for a second scope and there was a cancer that was missed within a year period. And that's because the bowel prep was not clean. So it's so important to have a clean bowel prep. And most of the people who are doing these scopes will tell you, the bowel prep is not clear. I think you better come back for another scope again in the next few months, because we don't want to miss something and give you a false sense of reassurance.
Right. Okay, and I think that's an important point of viewers as well, because sometimes you just have to kind of take that little temporary discomfort in order to get a good kind of an accurate result of doing the colonoscope. Okay, so we're going to take, I think, maybe about 1 or 2 more questions, Doc, if that is okay with you.
Yes. But Murali, I've got a question for you.
Oh, yes, Doc. Oh, wow.
Have you gone for your colonoscope or not?
Oh, actually, I'm just touching my 40th year, so I'm scheduling one.
All right.
I do IFOBTs though quite regularly, just to kind of make sure to answer the question when people ask me that whether I do IFOBTs. But I think I'm setting myself up for a colonoscope.
Awesome.
As part of my birthday celebrations.
Awesome.
I'll do, definitely, Doc. So I think one of the last questions someone has, okay, so which is this I think is a repetitive question, but I'm just going to field it to you anyway, Doc. It says, I have an auntie who has a tumor near rectum. Doctor says you have to have surgery and have a stoma bag in place. So I mean, giving this with a caveat that, you know, unless Doc knows the actual patient with the actual history, we can, I mean, Dr. Paul will be happy to give you a little bit of advice, point you perhaps in the right way, but yeah.
If someone has a colon, I mean, in this case, it's a rectal cancer, it's good to talk to your surgeon. It's good that your team, whether it's a general or a colorectal surgeon, and then see their expertise in managing this. A lot of time in our own place, we manage as a team. There's two of us colorectal surgeon with the oncologist discussing this as a, you know, I don't like treating cancer by myself. The oncologist is an important partner, and we decide together what is the best way forward. I think the first thing to remember is we need to cure this person of the cancer if possible, right? God willing, we can get rid of this cancer forever. And if in that case, removing the splinter and having a permanent bag is the only way to give them the best chance of survival, then I think they have to go for it. Now, if not, at least, if we can save the splinter by whatever way, whether by chemo, radio, and then doing a surgery, which is splinter saving. Now, this is going to be on the expertise of the doctor you are seeing. There are different doctors with different expertise, the general surgeon, the colorectal surgeons, you know. So you need to talk to your doctor. It's important to talk to your doctor, and then they can advise you on the best direction. I mean, just thinking on the top of my head, I would discuss in my team with my oncologist, and then see what is the best way forward for each individual patient. So you need to, you know, it's different for patient A and patient B, right? So you got to individualize the treatment based on where the cancer is, the type of cancer, whether it's aggressive or non-aggressive, and then make sure that we give them the best chance of survival.
Absolutely. Doc, there's an addition. I don't know whether this is helpful or not. The person has just typed that the tumor is stenotic.
Stenotic. Yeah, that means it's the narrowing in that area. But again, you know,
yeah, it's not some. Yeah. I think what you've offered is the best advice. And while you're on that, I just want to check with you again, because that you brought up this point on kind of the importance of having like an integrated care team working together.
That's right. It's so important, I think, especially in colorectal cancer. It is, and most cancers as well. There's no one-man hero, and there's no one hat that fits everybody. It is good, the pathologist, the surgeon and the oncologist work as a team. An 80-year-old with the same disease gets a different treatment from a 40-year-old with the same disease, right? So we work very closely with our oncologists and pathologists. They tell us what the margins and things like that, because at the end, we all are trying to get the same result, which is try to keep you cancer-free. If we can cure you, that's fantastic, and try to keep you cancer-free so your survival is better.
Okay, Doc, one last question, and then I'm going to call it to an end this evening. And this, I think, is an interesting one. So this person asks, can colorectal surgeries be done endoscopically?
Okay, so there's laparoscope, small holes that they put on the abdomen and remove colon. For endoscope, it's through the colon. Yes, so if it's very early cancers, that means T1, T2, very small early cancers in the rectum, we can put like a pot into the rectum and remove that cancer. And that's what the story I was telling you earlier about one with a very early cancer. We had another patient who came to us today as well with a very early cancer, and we could probably going to offer them after the MRI. But and it can be done, whether it's small hole, keyholes, and lots of us surgeons do offer that. Robotic, which I showed you a video of. And of course, this through the anus as well, what's called a TAMIS, T-A-M-I-S, transanal minimally invasive surgery, where we can remove these small tumors with fairly good results. But of course, they have to be a very close follow-up for the next few years.
Right. But is there any distinct advantage doing it that way compared to doing it laparoscopically?
No, because these are really small and close to the rectum. So the guideline tells us that T1 or early T2 can be removed, right?
Right.
So they don't have even a scar in the abdomen at all.
Right.
That's awesome.
Okay, lovely. Doc, so we're coming on the top of the hour. I'm cognizant that really we've kept you for quite a bit as well. And thank you once again for this wonderful session, and, you know, being patient, taking all our crazy questions. And hopefully that our viewers have really had some good insights this evening. As we bring the session to a close, you're wearing blue, and, you know, our title today was on blue as well. Any special significance on this blue color in colorectal cancer?
This is the color I wear to my surgeries, and I think it's basically being a colorectal surgeon, and the importance are, in fact, I don't have my tag here, I just carry feel awesome for something that we did before is basically to tell people, hey, March is a month to remember about colorectal cancer more, but don't forget, you know, it's throughout your lifetime. Remember, the new age is 4 and 5, 45. It's no more 5 and 0. So screening is much earlier. Only.
Okay, will do. Thank you so much. Ladies and gentlemen, this was Dr. Paul Silvandas, consultant colorectal and laparoscopic surgeon at Gleneagles Hospital, Kuala Lumpur. And Dr. Paul spoke to us this evening about colorectal cancer, and really, I think he has like literally filled our bowels with the idea and importance about screening. So if this is not a kind of message that makes you scream out and go and get screened, please at least take heed of that and look at getting yourselves screened for yourselves this March. So thank you very much, Doc. Pleasure having you this evening, and hope to see you again. Thank you so much, ladies and gentlemen. We hope to see you next month as we continue the Cancer and Eye series. And this is me, Murali, signing off. And we hope to see you next month at the same time, same place. Thank you and good night.
Thank you. Yeah.